All right, in this video, I'm going to go over the sympathetic nervous system. So we know there's two different branches of the autonomic nervous system, the sympathetic and parasympathetic. And this one we're going to cover is the sympathetic. So in the sympathetic, you can give a drug that's called a sympathomimetic. And basically, mimetic means the mimic. So if I gave something that was a sympathomimetic, that's going to increase the sympathetic control over the body. It could be over the heart, it can be over the lungs, wherever the sympathetic is controlling at that time. If we gave it something that's a sympatholytic, lytic means to cut or lyse. So we're basically lysing or cutting the sympathetic. So in that case, anything that's a sympatholytic is going to decrease the sympathetic control, which in turn will let the parasympathetic take over. So it's just another way for the parasympathetic to go ahead and take control of the body. So with this sympathetic, we have something that is a sympathomimetic. We're going to see a dilated pupils, which is called mydriasis. You're going to inhibit the tear gland, so you're not going to make tears. You're going to basically cut down on the flow of your saliva in your mouth. You're going to increase your heart rate, and you're going to constrict your arterioles. You're going to dilate your bronchi. You're going to slow down or almost stop your stomach from moving to where it's not secreting much chyme, and it cuts down on the movement or the motility. You're going to release epi and norepi out from the adrenal glands. This is up top of the kidneys. You're going to slow down, your intestinal motility, which basically is your peristalsis. So that will cut down or slow down if you have to have a bowel movement. You're going to constrict the neck of your bladder so you don't have to pee. And you're going to, for guys, it's going to stimulate ejaculation. All right, so I kind of teach this like if I was going to get in a fight. If I was going to fight someone, let's say I was going to fight someone who's bigger than me, right? And I want every advantage to my side. In that case, if I'm going to fight, I want my eyes wide open. So think about it. If sympathetic, fight or flight. If I'm going to fight, I want my eyes wide so I can see. So that's dilation of pupils. I don't want tears in my eyes. I don't want to be able to blur my eyes. So I want to shut that down. I won't be salivating everywhere. So we're going to inhibit that. I want my heart rate going fast. I want to be able to rock and roll. So my heart rate goes a little faster. And I want my lungs open. I want them dilated so I can get air in and air to my muscles what I need if I'm going to throw down and fight. When I'm fighting, I definitely don't want to peeing and pooping, right? So we shut that down, right? So you just, when it comes to the sympathetic or parasympathetic nervous system, the fight or flight or flight, or feed or breed, just think about what was going to happen in those two things. And it's sympathetic. If I'm going to fight, I want all these things to happen for me. All right, so with this lecture, we'll talk about adrenergic receptors, beta 1 and beta 2. Anything about how many hearts you got one heart. So beta 1 kind of basically is the cells in your heart, but you also have some beta 2 cells, but the majority is beta 1. In beta 2, you got 2 lungs, so think beta 2, 2 lungs. And then we'll talk about alpha 1, alpha 2. Okay, so you have 4 basically binding sites for adrenergic receptors, beta 1, beta 2, alpha 1, alpha 2. All right, so here we have the CNS, and pretend this is kind of like the spinal cord going down, so I just kind of threw this diagram together. All right, so here we have a preganglionic, so this would be the spinal cord coming off, and this would be your preganglionic, and then comes to a ganglion, which is basically just where nerves join together. And with the sympathetic, these come right the thoracic lumbar area, and your preganglionic nerve fibers are very short, and your postganglionic nerve fibers are very long. So here we have a preganglionic, and here we have a postganglionic, and this is a sympathetic adrenergic nerve. And the neurotransmitter is going to be acetylcholine, preganglionic, and acetylcholine is going to bind with what's called an NG receptor. NG is nicotinic ganglionic. All right, so the acetylcholine is released from the preganglionic neurofiber, and then the acetylcholine is going to bind with a NG receptor, which is nicotinic ganglionic in the ganglion. And it's going to send an impulse down the post-sympathetic nerve. All right, so here we have we're talking about beta 1 here, so we have a heart. In the heart, the adrenergic receptors are beta 1. So here we have a beta 1 receptor, and of course now the neurotransmitter is going to be norepi. So preganglionic, in the preganglionic, the neurotransmitter was acetylcholine. Postganglionic, the neurotransmitter is norepinephrine. Okay, and that's going to bind with a beta 1 receptor. And when that does, so beta 1's on your heart, when that does, we have an increase in chronotropy, an increase in dromotropy, and an increase in inotropy. And we're going to talk about that, what those are in just a second. Okay, so again, we have the nerve for your sympathetic come off your thoracic lumbar area, and your pre-ganglionic fibers are very short. Then you have this ganglion, which is basically just a junction of nerves come together, and then you have a post-ganglionic nerve, and your post are longer with your sympathetic. Your preganglionic neurotransmitter acetylcholine that binds with a nicotinic ganglionic receptor. And then that's going to go down, and you're going to get to the postganglionic receptor, which is going to be your beta 1 receptor. And we have norepinephrine that's going to bind there. And when norepinephrine binds, we have an increase in chronotropy, increase in dromotropy, and an increase in inotropy. All right, so let's talk about chronotropy. What is that? So chronotropy pertains to the heart. I always teach us, like, look at the first 3 letters, C-H-R. Excuse me, C-H-R. So abbreviation, cardiac heart rate. So chronotropy has to deal with your heart rate. All right, so norepinephrine binding to a beta 1 receptor will cause a positive chronotropic effect. So anything that causes a positive chronotropic effect will increase the cardiac heart rate. So again, chronotropy, first 3 letters, C-H-R, cardiac heart rate. With norepi binding to a beta 1 receptor on the heart, this is going to cause the heart rate to go faster. Inotropy. It's like anything about inotropy, like, I know I can. Here I am, or here's this little heart guy lifting up this. He's deadlifting his weight. I know I can. So he's basically looking at his contractile force. So inotropy pertains to the cardiac contractile force in your heart. So if you have norepi binding to a beta 1 receptor, this will cause a positive inotropic effect, which will increase the force of the ventricular contraction. So chronotropy sped up the heart. Inotropy is going to make the ventricles squeeze harder. With squeezing harder, you're going to increase your stroke volume. You increase your stroke volume. That, coupled with the increased heart rate, is going to increase your cardiac output. In the last of the 3, we have dromotropy. So dromotropy pertains to the speed of impulse transmission through the myocardium. Okay, so again, epinephrine binding to a beta 1 receptor will have a positive dromotropic effect. So anything that has a positive dromotropic effect is going to speed up the transmission of the impulses through the heart, which again, this kind of goes hand in hand with chronotropy also. All right, so now let's take a look at what happens when we have a beta 2 receptor. And again, where is beta 2 at? Beta 2 is in your lungs. So again, here we have the CNS. We have our little make-believe spinal cord coming down. And out there we have our preganglionic again. And then we have our ganglion. And in there we're going to have acetylcholine being released. And that's going to bind again to the postsynaptic neuron. And acetylcholine again is going to bind to a nicotinic ganglionic receptor. And it's going to send the pulse down. And here we're going to bind with beta 2 receptors. And beta 2 receptors are found in our lungs. So we have a beta 2 receptor. And again, the postganglionic neurotransmitter is going to be norepinephrine. Okay, so when this happens, beta 2 in your lungs. So when this happens, when we have a impulse come preganglionic to the ganglion, acetylcholine is released. It binds to the nicotinic ganglionic receptor. And of course, the impulse comes down. Then we have a release of norepinephrine, which binds the beta 2 receptor in your lungs, which all causes bronchodilation, which is what we want if we have any bronchoconstriction. All right, so in beta 2, we have norepinephrine binding with the beta 2 receptor. And here we have a picture of, let's say we have a patient that has an asthma attack, and we have some bronchoconstriction here. We have these muscles surrounding the bronchioles kind of constricted down, which is going to cut down the lumen. Maybe we have some secretions in here. And we give this beta 2 agonist, albuterol, let's say it's albuterol, and we have binding of the drug at the beta 2 site. Then we're going to cause bronchodilation, which is what we want. We want these smooth muscles around the bronchioles to relax, which is going to open the lumen of the bronchiole, which is going to make it easier for you to breathe. So over here, when I had this tightened, this constricted bronchial, I probably heard a lot of wheezing going on, because wheezing is air trying to make it through very tight areas, very tight bronchioles. Now we have bronchoconstriction. We're going to have more air movement, and we've probably cut down on the amount of wheezing we got going on. All right, so let's talk about what we have when we have an alpha receptor. So again, we have preganglionic, we have the ganglion, acetylcholine being released, and then we have, again, binding with the nicotinic ganglionic receptor, and now we're going to bind to the arteries. So this is an alpha-1 receptor. And again, the neurotransmitter is going to be norepinephrine. So basically nothing has changed in this whole thing with beta-1, beta-2, alpha-1. It's all the same. The preganglionic is very short. We have a ganglion, which we have a acetylcholine as a neurotransmitter. Acetylcholine is going to bind with a nicotinic ganglionic receptor, which is going to send the impulse down the postganglionic nerve, which is going to release norepinephrine, which is going to bind the alpha-1 receptor. And when it binds the alpha-1 receptor, we have very tight vasoconstriction. So this is going to be great, especially if we have someone who's maybe have allergic reaction, where their blood vessels are dilated, let's say anaphylaxis, and we want to give like epinephrine. Epinephrine is both the alpha and beta agonist. So with epinephrine, we expect to see vasoconstriction, which is going to increase our heart rate. Okay, so we have norepinephrine binding with an alpha-1 receptor, which causes a normal vessel or dilated vessel to become constricted. And that's what we want. We want to increase perfusion. So alpha-1, it's all about constriction of the vessels, which is going to increase my blood pressure. And alpha-2. So alpha-2 is usually not talked about. A lot of instructors don't talk about it because a lot of times they don't know a lot about it. Alpha-2 is basically just a negative feedback loop for an alpha-1. And basically, what does that mean? Well, a negative feedback loop in your body, basically is a check and balance system. So if you have one thing that does a positive effect in your body, you're going to have something that does a negative that opposes that effect. Basically, just to try to keep homeostasis. So something doesn't go crazy and go, just go wacko and just go totally berserk. All right, so basically what happens here is as a neuron is releasing norepinephrine to an alpha-1 receptor, well, on that neuron, you have an alpha, at the end of the neuron, you have these alpha-2 receptors. And as the neuron, as the synaptic terminals release this epinephrine, which is going to bind to the alpha-1 receptor, some's going to bind to alpha-2 receptors. And the alpha-2 receptor is then going to shut down or slow down the release of norepinephrine. So it basically says, hey, I'll let you release some, but don't release too much. So that's what alpha-2 does. Alpha-2 basically just keeps an alpha-1 in check. So we don't have a total massive vasoconstriction with everything shuts down. It cuts down blood supply to all your organs in your body and you die. Right? So this is just a check and balance system to make sure that alpha-1 doesn't go crazy. Okay, so a lot of times I teach when it effects on the heart, I teach this acronym called cardio. So C equals increased contractility. And that's an inotropic effect, right? It makes the ventricles contract harder. A is increased automaticity. And automaticity is basically the heart's ability to generate its own electrical impulse without the outside influence of the nervous system. All right. R is increase in rate, so it increases heart rate, and that's a chronotropic effect, right? D increases dilation of the coronary vessels. So I didn't go over, but there is this effect that's going to cause a little dilation of the coronary vessels, which is what we want. I is increase in irritability. So as you make my heart rate go faster, it consumes more oxygen. You do make the ventricles a little irritable. So sometimes you will give a drug like epinephrine. Epinephrine may be great to fix my blood pressure, but it might make my ventricles pretty irritable and upset, and they may start shouting out. And when you get to cardiology, they'll talk about these things called PVCs, premature ventricular contractions, and you may go into rhythms like VTAC, where you might have to give a medication or use some electrical therapy to correct it for the patient. And then O would be increased O2 demand. That's because we're making the heart go faster. We're squeezing, vessels down. We're going to increase the oxygen demand. When again, you got to think about it. So everything we do when it comes to medicine, you got to think about benefits and risks. So the benefits always have to outweigh the risks. So you could have someone who, already has, let's say, has a significant heart history. Let's say he had two heart attacks in the last couple of months. Well, maybe today he's having a severe anaphylactic reaction from being stung by a bee. So you get there and you guys say, okay, I gotta give epi, and I know when I give epi, it's going to cause the heart to become irritable because it increases significantly increases the heart rate, and it significantly increases the oxygen demand in the heart. And him having a heart attack, 2 heart attacks in the last couple of years, that's pretty bad. But in this case, this patient is suffering from severe anaphylaxis. The benefits outweigh the risk. I got to go ahead and give this epi to fix this anaphylactic shock, but I've got to be looking for the side effects that this patient with a significant heart history can go into. All right, so this is kind of just a synopsis of what we talked about. So again, we're talking about adrenergic receptors, and you have beta receptors. And beta 1 affects your heart, right? So beta 1, the receptor location is your heart, and the effect of binding to your heart is going to be increased chronotropy, increased dromotropy, and increased ionotropy. I guess chronotropy is cardiac heart rate, dromotropy is the speed of electrical impulses, and ionotropy is how much your ventricles are contracting. We also have another thing of beta 1, that's called a beta 2. And with the beta 2, those are located in the lungs. And with that, we have bronchodilation, which is what we want. If we have someone have an asthma attack or allergic reaction or a COPD, we need to bronchodilate. The other type of adrenergic receptor, we have an alpha receptor. And the one we really talk about with alpha is usually alpha 1. And alpha 1 is located in your blood vessels. And with stimulation of alpha 1 receptors or binding with alpha 1 receptors, that causes massive vasoconstriction, which is going to increase your blood pressure. We also have alpha 2. Alpha 2 is located in the synaptic axon terminals, right where it releases the norepi, and basically it inhibits the norepinephrine release. It's just a check and balance system to make sure alpha 1 doesn't go crazy.